Professor Abdul Karim, MEC, and all the guests, the panelists. Thank you very much for this evening's event. We have to apologize that we got oversubscribed and we ended up having to sort out the logistics for a while. But we want to welcome you all to this webinar. It's probably the first one we have tried. It's basically to try and share information on this COVID-19 outbreak. We have been given authority by President Cyril Ramaphosa and the National Coronavirus Command Council to take the public into confidence on some of the few issues that relate to some of the work that takes place behind the scenes before the National Command Council sits and takes decisions, and before the Department of Health takes any steps. There's quite a bit of work that gets done at the back. And so we want to welcome amongst our guests here a number of experts who assist us all the time to shape the thinking and look at what has to be a guide on what we do and what our next steps are going to be. So for this evening, we will basically just share briefly on some of the issues that relate to the decisions that get taken and some of the ideas about what needs to be taken into account as we move into the future. So it's going to be a very brief discussion. It shouldn't take us more than an hour. But we want to welcome all the experts who are aware that amongst us there are various experts from the diverse professions, particularly in the health sciences and social sciences. We want to welcome you. We're also aware that there's WHO representation. There are also journalists from various newspapers, and at the moment here we've got the three who are going to be running live, and that is SABC TV and E-News, or ENCA, who's going to be running live, and Newsroom Africa, we're going to be running live. So we want to say thank you, because it's really trying to share information and also make sure that our public gets a sense of some of the issues that are involved. So most of the debates and questions are likely going to be coming from experts who are really more in the medical or health sciences field, and so we're looking forward to that interaction. At this point, I'd like to just start by making a very brief report on some of the activities, as we normally do, to just give a sense as to where we are as a country in terms of our response to COVID-19. We do realize that it's still early days for us, and that it's going to be a very long and hard struggle, and that we need to really be prepared to move on the whole way to deal with this issue of COVID-19. We have also seen that the whole world has moved up to 1.8 million people who are involved. Some of the countries at almost at over 500,000 already. So it is quite a serious challenge that we must all brace up to facing, as it were. And also it's important to say that it's the public, it's the society in general that has to participate in this fight. And so it's important for us to keep sharing information with them. So you would be aware that we have announced, President indicated that there's going to be a whole program to start public screening, mass screening, and testing. So I want to just give you a quick sense that at this point we have managed to screen 438,815 people in the whole country. And this is, again, as I said, early days, but that's where we are now, 438,815. And we have referred out of that total 4,537 people for testing, who have gone into various government facilities for testing. We have also identified, of the people that have been found to be positive, 11,406 contacts. Of those, already 9,675 have already been identified and interviewed and also processed accordingly. We have on the ground an army of 10,654 tracers who are on the ground moving to meet all the people and try and make as much of the contacts as possible. In addition, the cumulative total number of tests that have been done at this stage on COVID-19 are 83,663, and that's the total. 21,190 of those are from the public sector. We'll note that that number is beginning to pick up more now as compared to the past few weeks when largely the tests were done in the private sector. So the latest number of positive cases today is recorded at 2,272. That means we've got 99 new cases recorded. So that's the latest total, 2,272, with new 99 recorded for today. Regrettably, we have also recorded 2 deaths that we are now able to confirm at this point. One from the Western Cape, and a male who's 68-year-old who came in acute respiratory distress and hypoxia with underlying concomitant diseases of diabetes, hypertension, and chronic renal disease. And this has been the pattern for most of the people that we have seen where there is some underlying ailment, as it were. But the one in Gauteng is the one that's raising quite a bit of concern to me, is the 57-year-old male who has been was admitted in acute respiratory distress, was taken ultimately to ICU, and then his chest X-ray showed some changes which were suggestive of COVID, and of course COVID-19 was confirmed to be positive. And whilst in the ICU, his condition took the turn to the west, and unfortunately we lost him. We do not have the record of any of the underlying diseases. We want to convey our condolences to the families who have lost their loved ones. We also want to convey our appreciation to the staff that has done everything to try and save the lives of those of our people. May their souls rest in peace. And therefore, at this point, I would like us to move on, just to clarify as well for the public to understand that when we issue the numbers, at the moment they are not live numbers. They actually get calculated at midnight, and then we do the clearing of all the figures during the course of the day and doing all the reconciliations. So sometimes when you hear the reports, some people saying we've seen more patients than what is reported, there's just the lag that we do have to experience as we move along. When it comes to patients who are deceased, we wait for the full report. In some instances, we have to wait for postmortems, we have to wait for a full clinical report in terms of what has happened, and as well as a confirmation that the person did in fact have positive tests on COVID, and therefore we'll find that there might be a bit of a delay in the announcements of deaths. But at the end of the day, we will have all of them reconciled such that we are able to report accordingly. Having said so, I'd like that we get the introduction of the experts that we have invited. Leading the team is Professor Salim Abdul Karim, who is the chairperson of the Ministerial Advisory Committee, which is a wide committee of about 45 people that includes about 20 professors from the various disciplines on health. That would be infectious diseases specialists, physicians of various descriptions, virologists, immunologists, microbiologists, epidemiologists, and a whole spectrum, including intensive care specialists, pediatricians, and so on. So this team basically meets and every now and again looks around at what is the experience on the ground and what is the experience on the research, and put together various guiding issues that must therefore guide the response of the health department. In there also are some of the health policy members from various parts of government who are here. So the presentation today is going to be given by Professor Abdul Karim, and then there will be commentary from some of the experts, and then we'll open up for questions. And of course, we hope that one day we'll be able to repeat this, but a bit of a new issue for us. May I just ask that we get the presentation of the specialists, if they can just be introduced briefly for everyone to understand the background from which they have come. Thank you very much, Chief of Staff.
Thank you, Minister. Professor Salim Abdul Karim is a South African clinician, clinical infectious diseases epidemiologist, who is widely recognized for his scientific contributions to HIV prevention and treatment. He is the director of the Center of AIDS Program of Research in South Africa, that is CAPRISA, and has professorship at Columbia, Cornell, Harvard University. He is also the Pro-Vice Chancellor Research at the University of KwaZulu-Natal, South Africa. He has served as the president of the South African Medical Research Council and is currently serving as the chair of the Ministerial Advisory Committee on COVID-19. Professor Abdul Karim has received a number of international awards for his work, including the American Academy of Microbiology and Association of American Physicians. We also have Professor Glenda Gray, who is joining us via Zoom. She is a South African pediatrician and an NRFA-rated scientist who is widely recognized for her scientific contributions towards the prevention of mother-to-child transmission of HIV and HIV vaccine development. She is currently the CEO and president of the South African Medical Research Council. She holds academic positions as research professor at the University of Witwatersrand, Department of Pediatrics, as well as full professorship in the Vaccine and Infectious Diseases Division of the Fred Hutchinson Cancer Research Center. She also has received the South African highest honor, the Order of Mapungubwe, for her pioneering research in the prevention of mother-to-child transmission. We have Professor Kolega Mlisana, who is the Executive Manager, Academic Affairs, Research and Quality Assurance at the National Health Laboratory Service. Prior to this, she was the Associate Professor and the Head of Medical Microbiology Department at the University of KwaZulu-Natal and NHLS, based at the Inkosi Albert Rutuli Central Hospital. Her previous contributions, including being a co-investigator and project director at CAPRISA, and she has undertaken seminal research which has revealed how the body responds during acute HIV infection. She was the protocol co-chair and project director for more than 10 years. Right now, she's currently conducting research into TB diagnostics, drug resistance, as well as sexually transmitted infections, and has co-authored more than 130 peer-reviewed journal articles. We also have Professor Brian Williams, who is joining us from Switzerland in Geneva. He was an epidemiologist at the World Health Organization, based in the Stop TB department. His primary interest is in the epidemiology and the control of TB, especially in Africa and in places where there is a high burden of HIV infection. He has published papers on a range of diseases, including measles, silicosis, malaria, TB, and HIV. He contributed to the development of the new global plan to stop TB and has helped to develop policy in the management of HIV-related TB. In 2005, he was part of the team that reviewed the South African National TB Control Program. Much of his work at the WHO has been concerned with understanding the way in which HIV epidemic drives TB incidence and prevalence. Minister, we also have a number of clinicians on the line, scientists, that includes Professor Rees, who is the chairman of SAPRA and is involved in the WHO Solidarity Trial research. We also have Dr. Kerrigan McCarthy and Dr. Natalie Myatt, who are the part of the management and leadership at the NICD. And we also have Dr. Kalua, who is the director for WHO on the line. Thank you, Minister.
Thank you very much. There's also Professor Olive Shisana, who's the special advisor to the President. And in the process, I'd like to just say that this presentation just give you a glimpse on some of the work that goes to advising the provincial MECs and the Minister of Health and the Management of Health, together with already been seen by the what you call the net joints, which is the Directors General in the government, the Special Social Protection Cluster in government, as well as the National Command Council, National Coronavirus Command Council, which is chaired by President Cyril Ramaphosa. So that the discussions are going on. This is just to share some of the information, some of the science behind some of the actions that have been taken and some of the trends that give us a direction as to where we might be going. But we're not talking about decisions. We just want to share what lies behind the discussion. At this point, I'm going to ask that Professor Abdul Karim takes the presentation. Thank you very much.
Thank you very much, Minister. It's indeed a pleasure and an honor to share with you today just a brief look at where we are currently in the COVID-19 epidemic. I'll talk about some of the trends, and I'll talk about some of the next steps. And I will cover in this time, next slide, I will cover briefly an overview of the different aspects of the COVID-19 epidemic, and then go on to talking about our response as this, in terms of what we've done at a national level. You can get the next slide. Okay, we're just trying to get the slides up so you can follow me. Okay, next slide. So as we think about the coronavirus epidemic, we now have a clearer understanding of how it originated and what the early trajectory of the epidemic has been. Next slide. And that, when we look at the earliest reports, we now know that the first cases probably occurred around November of last year. But the first reported case was in 19th of December last year from the Chinese city of Wuhan. It's thought that the initial epidemic, the cases emanated from the seafood market in Wuhan, where among the things that are considered to be the source of the virus are pangolins that were sold there. Since then, it is quite amazing that when you think about, we didn't even know this virus existed 4 months ago, that in the short 4 months that we've known about it, we have seen us go from a small outbreak related to the seafood market to a situation today where we have just over 1.8 million people infected. And that gives us some indication of how rapidly this epidemic can grow. Next slide. So when we look at each country and the way in which the epidemic grows, we can see that once a country reaches about 100 cases, the epidemic grows at a rapid rate, what we call an exponential curve. That exponential curve reflects the high numbers of new infections that occur almost daily. And so what happens is that When this epidemic reaches that stage where you have this exponential curve, where the number of new cases is increasing very rapidly, that as they start developing clinical illness, they then need to come into medical care. And so the medical care systems get swamped and they get overwhelmed in dealing with the large numbers of cases. If you think about it like this, that a disease like HIV, from the time you actually acquire the infection to the date on which you will get symptoms, is on average about 7 years. In the coronavirus, from the date you get infected to the date on which you're likely to get your first symptoms is only 7 days. So you are dealing with an epidemic that grows very rapidly and where the patients get clinical illness at a very rapid rate. Next slide. So when you look at the South African epidemic, this is a graph you're very familiar with, that day after day we count the cumulative number of cases and we present that. Next slide. But if you look at the trends, and this diagram is intended to give you a sense of the trend, what you see is that South Africa was on an upward trajectory. We were entering that exponential curve where the number of cases was increasing rapidly. And then on the 26th of March, it took a turn. On the 26th of March, instead of continuing a straight upward exponential curve, the epidemic took a turn. And what we began to see, a decline in the number of cases, and then we reached a stage of what we call a plateau, where we were just seeing a similar number of cases every day. Now, the 26th of March is significant because that was the date of the lockdown. And if we look at the number of new cases, next slide, it becomes a little bit clearer. So this is the moving average of the number of new cases in the dark line. The light line tells you the actual number of reported new cases each day. So when you look at this curve, what you can see is that we were on a simple trajectory like every other country, increasing rapidly day by day. And then suddenly on the 26th of March, it turned and started going down again. And as it went down, it reached a point somewhere around 60, 70 cases a day, and it sort of hovered around there. Now, each day's numbers offer a lot of variability, and a lot of it is just background variability and noise. So it's better to look at it in terms of a moving average and to look at it in blocks of time so you get rid of some of the background noise and look at the average numbers. Next slide. So why is South Africa not on the expected COVID epidemic trajectory? Next slide. I've chosen to compare South Africa with the UK just because for the first 2 weeks or so, the number of new cases we had in South Africa was virtually the same as the number of cases that we saw in the UK. In other words, in the initial period, the new cases in each of our countries at that point, after we reached 100 cases, was very similar. Suddenly, on the 26th of March, our line chooses not to continue the same upward trajectory that you see in the UK. That's not to say that our two countries are comparable, but certainly the initial trajectory of these two epidemics was similar. So what happened on the 26th of March was that we saw that as the numbers declined and became stable, the line sort of flattens out. And that's the difference between the two trajectories that you see. Next slide. Is that unique to the UK? Well, let's compare the South African line. And you can see again in the black, there's this little line that looks like a sort of a knuckle, where it goes up sharply and then takes a turn, and then it flattens out. If you look at that line and you compare it to a range of different countries, and I've chosen here to compare it against the US, the UK, Italy, China, it gives you some sense that every one of these countries, when they get into that upward incline where we see that exponential line, it simply keeps going. Not a single country that we have seen has this kind of turn. I've also compared our epidemic curve to some of the most successful countries, countries that have been able to make quite a marked impact on the growth of the epidemic. And those in particular, South Korea and Japan and Singapore. So when you compare our epidemic, you can see that Singapore was able to make an early impact and to create a much more steady growth in their epidemic. Whereas if you look at South Africa, there's been no other country. So our epidemic trajectory is unique. No other country has reached that point and has been able to reach a stage where you get that kind of plateau. So why is South Africa different? Why is it that our new cases declined and have reached a plateau? Well, there's three possible reasons. The first, is it that we're just testing less? Is it that we're just not doing enough tests, and that's why we're just seeing fewer cases? Is it that we actually are still doing a lot of tests, but we're doing them mainly in the private sector and not in the public sector? And so we're not getting a sense of what the epidemic is doing in our poorer communities that don't have medical aid. Or the third possible explanation is this reduction genuine? What's the likelihood that it's genuine and that it's due to the interventions that we have implemented? Next slide. So in this slide, I'm showing you on the left-hand side, this is a graph of the number of tests that are being done in the public and private sectors combined. What do you see in that? You see that over the 2 weeks in which we saw the South African epidemic go into a sort of plateau phase, what we see is a continual increase in the number of tests that are being undertaken. So it's certainly that we didn't do much fewer tests. In fact, the overall numbers of tests have steadily increased in the last 2 weeks. So that eliminates that, or it reduces the likelihood that it's just simply a problem of lack of testing. Lack of testing may be a contributor, but it's certainly not a dominant one. So are we not testing the poorer communities? Well, if we look on the right-hand side, that's the daily number of tests that are being done by the NHLS. The NHLS is the public part of the laboratory service. And so all of our poorer communities without medical aid will be coming to the NHLS for their testing. And what do you see? Just at the time that you saw the plateau in the South African trajectory is the point at which the NHLS sharply increased the number of tests that it's doing. And we've seen that steady increase in the number of tests in the NHLS. So it's not because we're not testing in the townships and the communities. It simply has to be a third explanation. So it's unlikely due to a lack of testing, or a decline in testing. It's unlikely to be due to the fact that we're not testing in the communities, the poorer communities. So it's most likely to be due to some genuine effect. So let's look at that. And it's not something we can say definitively, but we can say that that's the likely situation. So our COVID-19 cases have declined over the 2 weeks, while the NHLS test numbers have increased, and while testing in people in communities without medical aid has increased. We still need to do more in terms of testing, but certainly what we have seen is an increase. Next slide. So let me talk now about community transmission. Remembering that the lockdown is essentially about reducing community transmission in South Africa. Next slide. So I'm going to explain the 3 waves that we see in the South African epidemic. The first wave is the blue line. So I want you to look at the top left-hand corner. The blue line shows you the cases that occur in travelers. So what is that epidemic about? That epidemic is about individuals from South Africa who traveled overseas. They went to Italy, they went to the UK, or wherever they went to. They acquired this coronavirus infection. They came back to South Africa, and that's the first wave that we saw. Now that wave is coming to an end, and it has to come to an end because we stopped international travel. So because we closed international travel, those introductions of the virus. Now remember, outside of China, every other country has to have the virus come in from the outside. right? Because this virus is not present in the countries. So it's the travelers that have to bring it in. So the travelers become that first wave, that blue wave. The travelers then interact with people at work, people at home, people they travel with, and importantly, when they go into a healthcare setting, they interact with doctors, nurses, and so on in the hospitals, in the doctors' rooms, in the clinics, and so you see nosocomial transmissions. So all of those constitute the red line. Now, we expect that the blue epidemic, the travelers...
Can I just ask, can you ask the cameras to focus on the slides, so that the people out there can see the slides that is being explained? Yes, just take the nearest set and try and see if you can focus so that everyone can see the slides, because it makes it easier to understand. Our apologies, we didn't realize that we're getting left behind.
My apologies. So I want to talk about the 3 waves of the South African epidemic. So I want you to look at the top left-hand diagram. So the first wave is the blue line. And the blue line is about infections that occurred in travelers. So these are people who traveled, came back to South Africa, they got infected during their travels, and then they become the main source of the infection in our country. They interact with people at home, at work, wherever it is, and in the course of those interactions, they spread the virus to those individuals. And so you get the second wave. And these people here in the second wave are those who have had some kind of interaction with the travelers. Now, what we would have expected is that the blue wave and the red wave would lead to the green wave. And the green wave is about general community transmission. In other words, that the travelers and their contacts will spread the virus within our general community, and we will see this rapid liftoff, this takeoff on the number of infections that occur. And that's the line on the top right-hand side that we expected. We expected to see an exponential growth in our epidemic. But that didn't happen. Instead, and now I want you to look at the bottom left-hand corner, what we had was the epidemic, the blue in the epidemic, the first wave, the blue infections, the infections in travelers, and the red infections, which were those in their contacts and nosocomial contacts. But for some reason, those two groups did not lead to the establishment of a widespread community epidemic. We still see community transmissions, but they're at a low level. So the green line is at a low level.
Sorry, we're getting some complaints of people who missed some of the slides. Could I just ask for just 1 second, if you can just go back quickly on a few of the slides, just so that they have a sense,
Okay.
then we can
Then go to the next slide.
2 seconds. Yeah.
Next slide.
Please, can you have the...
Oh.
Yes, thank you.
I was just making the point on this slide that every country, once they've reached about 100 infections, they have virtually a non-stoppable epidemic. They have this rapid exponential increase in the number of infections. Next slide. But the South African epidemic has been slightly different. Next slide. And what we're seeing instead is that in the South African epidemic, we were poised to get this rapid increase. And it increased up to the 26th of March. On the 26th of March, the day we instituted the lockdown, the epidemic curve turned. What happened is that the number of cases declined and we went into a plateau. Next slide. And this becomes more clearer when you look at the number of new cases each day. In other words, don't look at it cumulatively. Just look at the absolute number of new cases. And if you look at the moving average, what you see, again, is that the number of new cases increasing rapidly until you get to the 26th of March, and then it turns. It turns, it heads back down, and it gets to a sort of plateau level roughly around 60 to 70 infections every day. Next slide. And that we know that we now have a different trajectory. The epidemic has followed a different pattern in South Africa than we see anywhere else. And this diagram shows that when we compare the South African epidemic to the epidemic in the UK, the epidemic in the UK is the yellow dots, and the epidemic in South Africa is the blue dots. When you look at the first 2 weeks or so of the two epidemics, they are very similar. They track with each other. And then on the 26th of March, our epidemic takes a turn, whereas the UK epidemic just continues its straight line upwards in the exponential curve. Next slide. So it's not unique that our epidemic is different from the UK. Our epidemic curve, the black line with the little knuckle that turns and flattens out, you can see it differs from all of the other epidemics, and I've chosen just for illustrative purposes, to compare it with the US epidemic, the Chinese epidemic, the Italian epidemic. So you get a sense of how our epidemic compares with most of the other epidemics. And even if you take the most successfully controlled epidemics, and that's Singapore and South Korea, for example, our epidemic has a completely unique picture to it, in that South Korea had that sharp upward rise, and it took them a long time before they turned it and made it flat. And you can see in Singapore that they have a much slower increase in their epidemic. But they do not have this kind of knuckle, where it was on its way up and then it turned. Next slide. So the question is, why are these two lines different? Is it that we just decrease the amount of testing? And if you look at the left-hand diagram, what you see is that actually the testing has simply increased. Over the 2 weeks that our epidemic has sort of reached that kind of plateau, the testing was still continuing to go up. And if you look at the right-hand side, is it that we were just not testing in our poorer communities? And the answer to that, if you look at the graph, which shows you the daily number of tests being undertaken by the NHLS, you see a rapid rise in the 2 weeks. So in the 2 weeks in which we actually achieve this plateau, we have a rapid rise in the number of tests being done in our poorer communities. Now, we're still not testing enough. We've got to be doing a lot more testing, and we're going to come back to that in a minute. Next slide. So it looks like our trajectory is different. It's unique, and it looks like it is not simply due to a testing issue. The testing might be a contributor, but it's not a predominant one. So how much of community transmission is there? And that's where I was when we went back to the slide. So can I take me to the three waves? Okay, good. So I'm going to explain this because this is central to understanding why our graph is different. So every country other than China, the epidemic, the virus, has to be introduced into the population by travelers. You have to go somewhere, get the virus, come back into your country, and when you come back, you get infected. When you do, you become the main source of the rest of the spread, because the virus doesn't exist in our country until it's brought in by travelers. And most of these travelers have no idea that they picked this virus up. They are doing whatever they were, and this was at a time when the virus wasn't even widespread. And so when they came back to our country and they started becoming clinically ill, we began to see this epidemic. But the private sector did a pretty good job. Many of these travelers had medical aid, they went to the laboratories, they were tested, they were cared for in our hospitals, and we are now seeing the tail end of that epidemic. Just the last few of those travelers we are seeing at this time. And so the blue line is an epidemic that is on its way to an end, because we stopped all international travel just about a month or so ago. The next wave in the epidemic is the contacts. So these are the people that the travelers mingle with. They mingle with them at work, they mingle with them at home, they mingle with them in the transport systems, and they also go, when they get sick, into healthcare services, into hospitals, into doctors' rooms, into clinics. And so you get the second wave of people who get the coronavirus infection. That's shown in the red line. It is the blue line and the red line that combine to provide and seed the community with the virus, so you get general community transmission. When it enters a community, it spreads like wildfire. And so you get the green line, that rapid increase in transmission in the community. And so you would expect to get the line in the top right-hand corner, right? So that's that exponential increase. Instead, what we had in South Africa as an explanation for why we have this odd trajectory in our epidemic, if you look at the bottom left-hand side, you see the blue epidemic, the blue wave in the epidemic. You see the red wave in the epidemic. But the green, we just are not seeing that community-level transmission at this time. So because the community transmission is there, we see cases, but it's not spreading like that wildfire that we had expected. And that's what's leading to this funny turn in the epidemic and the shape of our curve, which is quite different. Next slide. So, why did South Africa not follow the expected epidemic curve? Well, I explained to you that the first and second waves, the blue and the red wave, didn't really bridge and lead to widespread general community transmission. If it did, we would have been on that rapid upward trajectory. So we simply did not see that exponential increase. And if we look at the daily numbers of cases, if you look at the 2 weeks prior to the lockdown, the average number of cases that we were seeing per day was 65. If you look at the number of cases we were seeing on average in the 2 weeks after the lockdown, it's 72 cases. So if you look at one of the most important measures in an epidemic, is called the reproductive rate of infection, shown as R0. R0 basically means each infected person, how many other people are they infecting? So if each infected person is infecting one other person, the epidemic remains at a pretty static level. If one infected person is infecting more than one other person, the epidemic grows. If one infected person is infecting less than one other person, the epidemic goes into a decline. Right? So R0 around 1 is our key measure. How much higher or lower than 1, or how much is it around 1? When we look at our situation, roughly, because of the infectiousness period, we can say that each infected person, on average, is leading to about 1 new infection. And so that's why we see this line. We're not seeing a situation where one infected person leads to many. Why is that the case? Well, that was exactly the purpose of all our interventions. That's exactly the reason why we instituted all these things. Social distancing, hand washing. It's also the main reason we instituted interventions that led to a situation where people were not interacting with others. So when you think of a lockdown, essentially what you're talking about is that each infected person becomes a dead end. They don't transmit it to others because they're not interacting with others. So we know from that we simply are not seeing this growth in the epidemic we expected. And that right now we're not even seeing much evidence of clinical disease. We're not seeing large national increases in the amount of respiratory distress. In short, if community transmission is low, cases decline. If community transmission is increasing, then cases will increase and the exponential curve will start again. And community transmission is the central feature of what we're trying to control and stem. Next slide. Where are we concerned? What are we concerned about in community transmissions? Well, our 3 biggest concerns are in the 3 high-density hubs, where we have a lot of infections and where the potential for spread is high. It's high because we have so many people with the virus, and we have so many communities where it could be seeded and where it could spread. So our big concerns are around the greater Johannesburg area, the greater Cape Town area, and the greater eThekwini area. Those are the three hubs. If we start seeing community transmissions at a significant level, those three hubs are going to be the most likely places where it will start. Next slide. So let me end off this section on the epidemic by talking about some future scenarios. What are we going to see? So what I've told you so far is about the history. I told you about how the epidemic occurred. I told you about where the epidemic is now. Now let me tell you about some thoughts about where the epidemic may be going. So what's next? If you look at the top left-hand diagram, again, I've shown you our little funny line that doesn't match anybody else's line. So what's going to happen next? What we would hope for is in the dotted line, that the number of new cases will steadily decline and it will disappear, and that's the end of the story. I'm sorry to tell you that that's very unlikely. The more likely scenario is on the top right-hand corner. And that is that what we've managed to do is to stem community transmission. But once we end the lockdown, and we're going to have to end it at some point, once we end it, because about 55 million people odd are vulnerable to this virus. Remember, this is a completely new virus. No one in the world has encountered this virus before. This is a completely new virus. We have no immunity. We have no vaccine, we have no treatment, we have no immunity. So that means we're all at risk. Doesn't matter whether you're white, black, young, old, it doesn't matter. You're at risk because you have no protective immunity. And that's why, as soon as the opportunity arises for this virus to spread, we are likely to see the exponential curve again. We looked at, and people have looked at other epidemics. So colleagues in India have modeled the Indian epidemic, and they are also currently in a 21-day lockdown. And basically what they show is that the epidemic is starting to go up, you institute a lockdown, and basically at the end of the lockdown, the epidemic is likely to come back. Then you can look at Wuhan, where they institute a very long lockdown, right? Something like, 50, 60 days of lockdown. And they then waited for no local transmissions for 7 days before they lifted the lockdown. Well, it's left to be seen. Are we going to see another small epidemic in Wuhan? As soon as travelers start coming into Wuhan, reintroducing the virus, to what extent is the community doesn't have immunity, and we're likely to see new epidemics? We're going to watch that very carefully. Next slide. So I have to tell you that as much as we have succeeded in stemming the flow of this virus in our communities, in keeping community transmission at a reasonably low level, and that is a success that no one else has achieved, I have to tell you a difficult truth. Can South Africa escape the worst of this epidemic? Is the exponential spread avoidable? The answer, sadly, is that that's very, very unlikely. Put simply, no. We cannot escape this epidemic. Not unless South Africa has some special protective factor. Let's call it a mojo. We have some mojo that protects us that's not present anywhere else in the world. Our population is at high risk because all of us have no immunity against this virus. We've never encountered it before. So as soon as we end the lockdown, we will have that high risk. And so that's the issue we're grappling with. So why is it that it's so inevitable? Well, there are several reasons. One is that this virus, when you acquire the virus, let's say you get infected with the virus today, we expect that for the first 3 or so days in the incubation period, you will not transmit this virus. But thereafter, from day 4, day 5, up to the first 7 to 10 days, you are now infectious. You are infectious before you have symptoms. So you don't even know you have this virus, and you are in a position to transmit it. How do you fight something that you don't even know you have? And that's been our one challenge. Once you show symptoms, you are also infectious. And so you are infectious for another 2 weeks or so. So you have this long period of infectiousness that during which you're then spreading it around. And we know that normally when people are interacting with each other, this virus can spread really fast. In that, on average, an infected person will infect about 2 to 3 other people. So what does that mean if I say 2 to 3 other people? Think about it like this. If 10,000 people have the virus today, within a matter of 3, 4, 5 days, that 10,000 people will become a number like 30,000. And then again, another 4 or 5 days, and you're now at 90,000. Because each person is infecting 2 to 3 others, this epidemic within weeks can grow very rapidly. And we see that in that exponential curve. So what we have seen is a slight difference in our curve. And the government interventions have slowed the viral spread. The curve has been impacted, and we have now gained time. Next slide. So why is the delay important? Why is it that we should delay this viral epidemic? Why don't we just get it and be done with it? Because if we allow it to grow unchecked, we will see what you see in New York. You will see thousands of people trying to get into a hospital for care, and we simply do not have enough ICU beds or ventilators or medical care or any of that. We simply cannot care, we cannot provide care to so many people at one time. And so that's the challenge we're going to face. So we have time to flatten the curve, and South Africa has a unique component to its response. And that's quite important that when you talk about how do you tackle this virus, every other country has simply had to wait. They saw these cases coming into the hospital, and that's how they recognized they had an epidemic. In South Africa, we've chosen to go a different route. We've chosen to be proactive. We've chosen to go out there and do active case finding. We're not going to wait till they come to the hospital sick. We're going to go into the community. We're going to find them before they get to a hospital. And only South Africa has done that, because every other country, before they knew it, the epidemic was on top of them. Because we've had time, we now have, as you heard from the Minister of Health, we have over 28,000 community healthcare workers going house to house in our most vulnerable communities, screening them and referring them for testing so that we can find the new cases. This time is also an opportunity to give us an opportunity to find new, quicker, simpler diagnostics so that we're not dependent on this more difficult and expensive and time-consuming test that we're currently doing of PCR. It's also an opportunity to get new treatments, new vaccines, and all of this needs time. Now, we are unlikely to get a treatment or a vaccine within the next few months. Those things take, years. In our case, we hope that maybe we'll get it in a year, maybe 18 months. Our epidemic should be over by then. But they're important. They're an opportunity that if there is new data emerging, then hopefully maybe a new treatment becomes available. And importantly, it gives us the time to prepare for the medical needs to come. Next slide. So now I'm going to talk about the response. What I've talked about up to now is the epidemic. Now let me talk about the South African response. Next slide. So far, we have implemented the first 4 stages of our response. The first stage was preparation, where we set up laboratories and we started doing the testing at the NICD. And we started doing community education and so on. The second phase, when we declared the state of disaster, where we introduced social distancing, where we introduced hand washing, we closed the schools, we controlled the number of people who can attend a gathering, and importantly, we closed the borders so that we didn't have international travel. Then we went to stage 3, which was now our intensive phase, where we wanted to intensify the curtailment of human interactions. So every person who's infected becomes a dead end. They don't pass it on to anyone else because they're not interacting with them. And then we went to stage 4. Stage 4 is our surveillance program and active case finding with our community health workers door to door. Next slide. And this gives you some idea of how we have introduced each of those 4 stages of our response. So what about stage 5? What's next? Next slide. Well, what do we do this week? This week, we need to ensure that all of us follow the lockdown rules, and that we monitor community transmission. And the way we're going to do that is we're going to monitor the average daily number of cases that are occurring through the normal passive testing, that people get sick and they come in, and we're going to monitor our active case finding in our communities by looking at positivity among those who are screened. So when we look at the epidemic, in the week before we declared the state of disaster, we were having only 2 cases per day on average. So there's no question. We acted very early in this response. Almost no other country was in a position to act this early in the response, because by the time the cases started arriving, it just overtook them. In the first week after the state of disaster, we had about 21 cases per day on average. In the next week, the second week in the state of disaster, we had a rapid increase, right? You saw that, up to 110 cases a day on average. Then we instituted the lockdown, and that number comes down. We're now talking about 76 cases per day on average in the first week after the lockdown. And then in the second week after the lockdown, we're now down to 67 cases per day. Now you have to know that when there's a case today, that case reflects an infection from 2 weeks ago. From the time you get infected, you have a period in which you are in incubation. That takes about 7 to 10 days. Then you have to go to a doctor when you get symptoms, or a clinic or a hospital. Then they have to do a laboratory test. And then eventually when we get the answer, we call you a case. So we calling you a case today, you actually got infected 2 weeks ago. So when I talk about the average daily number of tests in the 2 weeks after the lockdown, they actually represent infections that occurred 2 weeks earlier. In other words, the infections themselves occurred before the lockdown. Next slide. So this coming week is critical. We need to know what the average number of cases is going to be. Why? Because we want to know what the community transmission levels are. Because we want to use that to guide us on what next steps we should follow and how we should manage the lockdown. So by the 18th of April, we will know if community transmission and whether our interpretation that community transmission has been kept low, whether that's accurate. And if we look at the 67 cases per day on average, the 95% confidence interval is 45 to 89. In other words, the true number of cases is between 45 and 89. So we are 95% confidence that the number of cases per day, even though we're seeing 67, there's some variability, and that variability lies between 45 and 89. So using that as an objective criterion, now we have an objective way based on the R0. In other words, how many people is an infected person spreading it to? If we base it on that, then we have a set of criteria. If the average number of daily cases, and we have to exclude active screening because that's not comparing apples and apples, but if we look at just the passive cases between the 10th and the 16th of April, and if we see 90 or more cases on average between the 10th and 16th of April, then we need to continue the lockdown. And the reason, put very simply, is that the average number of cases per day is going up. So the R0 is going above 1. And we don't want that. We want to keep R naught at 1 or lower. If we're seeing a number of cases between 45 and 89, then we are in the same region as 67, right, within the margin of error. And there we want to use our community prevalence. What is the active case finding telling us? And if that active case finding has a screening to positivity to screening ratio that is above 1 in 1,000, then we continue the lockdown. If it's below 1 in 1,000, then we can ease the lockdown. Similarly, if the absolute number of cases is 44 or lower, we can ease the lockdown because it tells us R naught is less than 1. So you can see that using epidemiological criteria, we create a set of a clear approach as to how to deal with the lockdown. Now you must expect that there'll be large daily variations, right? Because just the way the timing of the lab tests and so on. So you will see that. And you will see some large numbers, some small numbers. Don't let that bother you. You have to look at it over a period of time. And so that's why we look at a whole week at a time. And we compare weeks with weeks so that we're comparing apples with apples. We know that if we end the lockdown and we end it abruptly, we may run the risk of undoing all of the effort and the benefit we've achieved. Because then we'll be putting high-risk and low-risk people together, traveling in the same buses, taxis, trains. We have to do something about that. We have to avoid that situation. And so we need to think about and plan for a systematic easing of the lockdown, starting with transport hubs and then working our way down from the lowest risk to the highest risk. Next slide. Next slide. Okay, so once we have some idea and we now have a clearer sense of what's guiding, whether we extend the lockdown, whether we end the lockdown, how we end the lockdown, I hope I've given you a better understanding of that using epidemiological criteria. So what's next? Well, what we have to do is we have to get on with the next 4 stages of our response. So I talked to you about the first 4 stages. Now I'm going to talk to you about the next 4 stages, because that way you have some idea of where we are in our response. This is not a response we plan by the day. This is a response where we've looked at the totality of what we need to do, and now you can figure out where we are in that sequence. So what's next? Stage 5 is hotspots. We need to find out where the clusters of cases are occurring. We need to go in there. We need to slow it down. I'm concerned that things, for example, gatherings like funerals may lead to the spread of the virus. We've got to be very careful so that every hotspot that emerges, we can deal with it. Stage 6 is about medical care. We've already started stage 6. We are now in about week 4, week 5 of our planning for stage 6. So stage 6 is what we anticipate is we need to be ready for when those patients come. What does that mean? We need to ensure that we have the capacity, that we have the field hospitals for the triage. And I've shown you a picture here. In New York, Central Park was full of these field hospitals. Because what you want is you don't want people who don't need to go to hospital to go there. Hospitals get overwhelmed. So what we need, when somebody is sick, you go to a field hospital, a triage. In the triage, they then make a decision. Do you need to go to hospital? Because if you need to go to hospital, we've got to have ICU capability. We're going to be ready to ventilate you. But if you're mild, if you can be dealt with there in the field hospital, we keep you. So we hold the pressure off the main hospitals which are treating the seriously ill patients, because within a matter of days, they will have thousands arriving. Stage 7 is we have to deal with the challenges of bereavement. It's hard to say this. I know you don't want to hear this. But we have to be ready. We have to prepare now so that we can deal with the mental health consequences, we can deal with the social consequences that are going to see us go through a difficult period. Then stage 8, which is the ongoing vigilance. Next slide. I'll talk about stage 8 in terms of what we need to do in order to be vigilant. So Stage 8 is about ensuring that we're keeping one step ahead of the virus. I'm showing you this graph so you get some idea of how we are implementing our 8 stages, so that you have a sense of where we are and where we're going. And you have some idea of how we're putting in all the bits and pieces in our 8 stages of our response. Next slide. One of those stages that we've got to ensure that we're putting enough effort into, oops, next slide. Next slide. Is I want to talk to you now about stopping the small flames to reduce the risk of a raging fire. Next slide. So what we see is that when you're dealing with a virus like this, you get small flames. And I've used this cartoon of a forest, so you can see that within this forest, there's a fire here, there's a fire there. If you do not have people on the ground who can see these fires, who are looking for fires, we won't even know they're there. So we have to do that. And putting our community health workers onto the ground looking for the fires. Because within a matter of periods, as soon as we can see a fire, we can then respond to the fire. And those teams, those intervention teams that go with the hotspot identification, help us go in there and douse these little flames. Because if we get there too late, next slide, what we'll see is that actually now we're trying to put out raging fires, and it's much more difficult to put out raging fires than it is to put out a small flame. So we're going to focus on the little flames so that it never gets to raging fires. We're not sure if we're going to succeed. That's our goal. So stage 8. Stage 8 is about vigilance. Here, we're going to try and stay one step ahead of viral spread. This is a tall order. It's a really difficult thing to do because this virus spreads so fast. We are not going to wait for patients to pitch up at hospitals to act. We're going to do that now, proactively. What are we doing? We have 3 components to the surveillance. I've already talked about the ongoing community health care worker program. The second is we need to institute a surveillance program where 5% of staff from the emergency rooms, ICUs, respiratory units are part of a surveillance program once a month. Because they are the first point of contact in the healthcare system, they're like a canary in the coal mine. It tells us what's going on. It gives us a clue about where we are. We don't want to fight an enemy we can't see. We have to know where we are all the time. And so that brings me to the third component of our surveillance, that once a month we're going to have a National Surveillance Day. And the National Surveillance Day, we will select a small number of schools, mines, prisons, and big companies. We're going to aim to get about a 5% sample from these selected institutions, and we're going to do that once a month. We'll increase the number and the time in which we do it. We might go to fortnightly or whatever we need based on what we're seeing. We don't need to do that fortnightly just yet because community transmission is under control for now. But as it goes up, we'll want to know it more quickly. And so that will tell us what we're going to do. And we can do that initially, right now, with self-taken swabs. It's very easy to take a swab. And we hope that we'll switch to finger pricks once we have a rapid antigen test or some way in which we could identify those in a much more simpler way than having to take a swab. Next slide. So let me touch now briefly before I end off. What are some of the major concerns in stage 6? Because I could go on at length about each of the stages, but I just want to give you a flavor of the challenges we face in stage 6. So stage 6 is our medical care response. Remember, we've started already working on this. There are whole teams of people working on it. We saw from New York that blacks and Hispanics had twice the death rate compared to whites. And what we understand from that is that fundamentally it's about access to health care. We simply cannot allow that to continue in South Africa. We've got to make sure that everyone has access to care when they need it. So we're going to need an efficient ambulance system. We're going to need to ensure we have the healthcare ready to be provided. And we're particularly concerned that we have HIV-positive patients. We have about 2.5 million HIV-positive patients not on antiretroviral treatment. And we estimate roughly that there's about 500,000 of them who have a low CD4 count. They are immunocompromised. And so those individuals, plus patients who have TB, they may have a much more severe course of COVID. So we're going to need to make sure that we are preparing for a possible additional burden from those individuals. Plus, on top of everything else, we're going to have our COVID epidemic at the same time as our annual flu epidemic. I mean, every year we have our flu in the winter. We all know that. We get our headaches, our sneezing, and our sore throats. And now we're going to have to deal with it. I won't know whether you got flu or whether you got COVID. So we're going to have to deal with that burden in addition. But when I have to say all of this, one of the big issues we're going to have to think about is how do we protect the elderly? In particular, those above 70. Preferably those above 60 or 65, because mortality is still higher in that group. But above 70, we're really concerned. We need to think about whether it's going to be possible to have some kind of partial lockdown. And it can be a voluntary partial lockdown until the end of September or so, when we think the most of the wave of this epidemic will be over. I don't know it's going to be over on the end of September. I'm not a crystal ball gazer, but I've just provided that as a target for now. That if we can offer something to protect our elderly, right, and especially those with other conditions like diabetes, heart disease, lung disease, we know that those three were the main risk factors in the US and in China. Those individuals, can we provide them with protected self-quarantine and self-isolation, so that what it means is that our children will go to school and they play in school. When they go home, they can't play with granny. They cannot play with grandpa, because they will pose a risk to transmit the virus to their grandparents. We're going to have to protect our elderly in this period. We're going to have to build the field hospitals for the triage, especially in our big cities. And all of that's already well ahead in planning and so on. Those sites have been identified. And we need to get the staff ready. They need to know that we are going to head to this exponential curve. We need to have our makeshift ICUs, our ventilators, our PPE. All of them major challenges, because the whole world's trying to get all these things at the same time. So let me end off, next slide, with making some concluding remarks about where we are. So I've given you a sense in the course of this presentation about some key components of this epidemic and its response. First, I've told you that South Africa has a unique epidemic trajectory, that our current trajectory was a rapid increase, and because we intervened, and we intervened at an opportune time, we curtailed community transmission. Community transmission is continuing, but at a much lower level than we anticipated. I also gave you the bad news, the difficult truth, that we probably can't escape the exponential part of this epidemic. And that the lockdown has bought us some time. It has given us that time, that opportunity to become more proactive. And it's probably also dampened, it's flattened the curve. So when we see the peak, we won't see it in the same way as if we didn't have the lockdown and the other interventions we implemented. As we think about the lockdown and the timing of when it would come to an end, and that we can't end it abruptly, we've got to do it in a very systematic way. And we need to think about, in the next few weeks, as our focus shifts to stage 5 of hotspot identification, in other words, finding the flames, fighting the flames before they become fires. To stage 6, when we start preparing with all our medical care response, and then we move to stage 8, where we introduce our surveillance activities. Next slide. I want to end by just thanking many people. Minister Mkhize and I have spent quite a lot of time thinking through these issues, and many people contributed and guiding us and giving us information that made all of this possible. On that note, I'd like to thank you, and I'd like to hand over back to Minister.
Thank you very much, Professor Slim Abdul Karim. I know it's taken a little bit of time, but I'm sure everyone would agree it's worth the while. Just a bit of administrative issues. Firstly, those of you on Zoom, please put your questions onto the chat group directed to the host. Anything that's just on the general chat will not be considered. So look for the host and put your questions through that. I know that there are going to be so many already. We may not be able to cover all of them, but that's where we should direct them. Those who are watching on television at home, please use this number. I'm going to say it slowly. 082-678-8979. Those who are watching on television, you could send your questions on WhatsApp to 082-6788-979. And at this point, I'm going to request that our other panelists join us. Would like to invite Professor Glenda Gray to make some quick comments. If we could just make the arrangements for Professor Glenda Gray to give us some comments, and then we'll be followed by Professor Mlisana and then Professor Brian Williams. Thereafter, we'll open for your questions. Probably 2 to 3 minutes comments on the entire response and the epidemic, your thoughts, your ideas, if you could just take us through to that. Thank you. Can we connect to Professor Glenda Gray?
Thank you very much. So I'm just going to provide an overall response to the presentation, and Kaleka Malafani will speak about the testing response, and Brian Williams will address some of the issues around the interpretation of the epidemiological curve and the response and the data that we've just seen. So I think what I would like to first of all say is that we need a whole nation response, and the presentation that we've seen indicates that this is not all just about health workers, but everybody needs to buy into containing the epidemic. And this means minimizing social gatherings, continuing to have physical or social distancing, and to be vigilant about hygiene and issues around containing the epidemic. What we also need to do is have an evidence-based approach, and this is critical. We need to be nimble, and we need to adjust our response based on the data that's coming in. We need to understand better the community transmission and understand whether we are able to contain community transmission. And I think the next couple of weeks are going to be critical as we try and understand whether we've penetrated into the communities to make sure that we've tried to minimize and contain community transmission. So the next few weeks are going to be very important as we scale up community screening and triage people into testing. We need to learn from the field and understand the issues around reinfection and the trickling on of infections that we see in South Korea and in other countries, and that this epidemic is going to be around for a long time, and we're talking months and not weeks here. The active case finding is critical, and it's very important in trying to contain the epidemic. And also, not only is active case finding critical, but also contact tracing to make sure that we find the contacts and we make sure that they are isolated and that they are tested and evaluated for symptoms of COVID-19. The identification of hotspots is paramount, and the testing coming in now into the NHLS will hopefully tell us where the community epidemic is coming from and help us to try and monitor and locate new cases, trace the contacts, and also make sure that we understand exactly how the epidemic is panning out and how important community surveillance is, and the issues around testing and screening in the community. Vigilance to outbreak investigation is very important. We've seen the outbreak in East London prison and how to monitor and contain an outbreak and how to investigate it. So these we will continue to see, and we need to be vigilant to making sure that we investigate each outbreak and this obviously requires resources. Getting into the medical care, we need, the overall objective for medical care is to minimize the deaths in our country. And for this, we need a coordinated response. We need all healthcare workers hands on deck. We need the public and the private sector to work together to make sure that we all are ready for this response, and that everybody must move together to make sure that we can minimize death. So we do need public-private partnerships that help us maintain the epidemic and manage care. So the whole objective for clinical care is to make sure that we minimize deaths in our hospitals. We also need to make sure that we protect our healthcare worker. We need to minimize deaths of healthcare workers. They need adequate PPE, they need adequate training, and we must make sure that they're supported both mentally and with the equipment and the training that they need. They are imperative to our response. These are our frontline workers, and we must make sure that they are well supported and protected and trained. We have to keep our hospitals open and for COVID-19, and as we come into the winter months, we do know that there will be flu and COVID-19 happening together. But we also have to minimize hospital admissions for other reasons. And the MRC has been looking at how to minimize alcohol-related admissions. We know that emergency care is taken up by alcohol use, and that a lot of the times we could keep our emergency rooms open if we contain the amount of alcohol people drink and minimize the emergency room issues. So we will be working more on the impact of alcohol use and how it impacts our emergency care and the use and trying to, in an effort to try and keep the hospitals open. The ongoing surveillance is critical, and this is long term, and this is not just for a few weeks, this is for months and maybe years, as we try and understand how the epidemic is going on. And so I would like to hand over now to Kaleka, who will talk about the issues around testing, and also to Brian Williams, but just to say that the whole nation needs to work together, and this is a long-term march and not a sprint.
Thank you very much, Professor Glenda Gray. Could you have Professor Kollega Mlisana to come in, please?
Just find her.
Okay, whilst you're trying to find her, can you just check if you can find Professor Brian Williams in the process? We'll pick whoever we get first. If you could just bear with us a little bit, our platform is oversubscribed, and it looks like some of the people get in and out of the meeting, and so we have a bit of a delay. It's not possible to do it quicker than that. Maybe whilst you're looking at that, let me just comment on some of the issues that have been raised, which I think is going to be very important. I like the whole question that's been raised. Protect our health workers. That we make a commitment that health workers have to be protected through training, through adequate protective clothing, PPEs, and through support, so that what we have seen also, as we're discussing with the unions, has been the level of anxiety amongst our members, which you need to deal with so that they feel confident to face up to the outbreak. And as professionals, our health workers are the ones who are well trained to be able to deal with the problems of infection control. So I think that point that's been made by Professor Gray is a very, very important point. I will make the comments until they find Professor Mlisana or Professor Brian Williams, and then we'll give them the space. But the other issue which I thought is important to underline from Professor Abdul Karim is the fact that we have said from the beginning that our efforts are going to focus on flattening the curve. I think it's important to make that point all the time. We want to flatten the curve. We will not be able to avoid the coronavirus coming through, but we would like to flatten the curve. And therefore, what we are doing already has indicated the first few steps of flattening the curve. Are we finding Professor?
Yeah.
Let me hold it there so that we can get Professor Kolekamlisana in. Professor Kolekamlisana, please come through.
Okay. Thank you very much for that. I'm sorry, I could not unmute. Thank you, Minister, for this opportunity. And I also would like to thank Professor Mkhize for taking us through some of these difficult concepts and simplifying them. And as Glenda has mentioned, I thought what I will concentrate on is just looking at issues around testing. Basically, if I use Slim's presentation, how do we identify these small fires? Because we need to make sure we identify them, contain them, before they become raging flames. So, and testing becomes critical. We have already heard that, we are now sending out community health workers into communities to actually look for individuals, screen individuals for symptoms. And anybody who has a list of symptoms that have been decided upon will then be referred for testing. Now, firstly, for me is to say we really are grateful that we actually have got these healthcare community workers, and to say to the nation of our country that we need to actually allow these healthcare workers to come into our homes, because we're trying to identify where the infections, if we have any, where are they hiding in the communities. So what then is going to happen is, as people get prepared for testing, the big question has been, can the testing facilities actually cope with the loads that we're expecting? Because as more and more people are screened and are referred for testing, the numbers that Slim was showing earlier on, we're expecting those numbers to increase markedly. One other thing that has been the result of the fact that our government has actually acted very promptly is that it has given us time to actually do a baseline assessment of what are the capabilities that we have for testing within the country. First, if we look at the NHS, as already mentioned, it is actually the largest public health organization that does testing for all public hospitals, and we cover about 80% of the population. And when we look at the capacity for testing COVID-19, we know that we currently can actually do as much as up to 30,000 tests per day, per 24 hours. And which therefore means there is that capacity that is already in existence. And not just NHS alone. Remember, this is a whole, it's a national epidemic. And if you look at the private pathology labs, there's another 10 to 15,000 tests that can be done by the private sector. And not just the private pathology labs together with NHS alone, but we have got quite a number of research institutes, within, either based within medical schools or, for instance, the CSIR, that have got capabilities to do the testing. And that gives us another additional 10. So really looking at the numbers and the capacity that we have as a country, we can ramp up to something like 50,000 tests per 24 hours. So what is now currently happening is to then try and make sure that we secure all the reagents that we require and whatever consumables that are necessary to do such high scaling of testing. So when we look at testing capacity, we think we have been given enough time to prepare for that. Now, the next thing that really for me is very, very critical is, like I said earlier on, to say to South Africans, the next 2 weeks, already mentioned, are really very critical, because we need to then identify where are these fires. And so it's going to cause each and every South African to remain indoors as has been requested, and allow and open our homes for testing. And when actually we have been screened and you have been identified to have symptoms, make sure you then present for testing so that we then can identify, because once then somebody is tested and you are found to be positive, then you need to be isolated, whether it's self-isolation or it's assisted isolation. And so all your contacts need to be identified so that you can put these small fires out before they become large flames. So, and also I think what I must emphasize as well is that when healthcare workers come to your home, they do a screen of symptoms. So they're going to ask you certain questions and they will refer you to testing. When you go for testing, I promise you, we use sterile swabs to collect samples. And don't listen to fake news that have been going around. So all that that will be done at the testing site is that we will take either a nasopharyngeal swab, which is sterile, it has not been used before, and we either a nasopharyngeal or an oropharyngeal swab, and that's the sample that gets sent to the lab. And as far as the lab is concerned, we are all working, almost 24/7 to make sure that the turnaround time, the time that the results become available, are within, the required time, so that there's not a long lag of time before people can get their results. And really, for me, it would just be to appeal to every South African that this is that we really have seen the gains of the intervention that have already been introduced. And now really, let's just strengthen that even more and make sure that we all participate and we truly can flexible care. We may not necessarily avoid some interest in cases, but we definitely can flexibly care, and we find that we don't overwhelm our healthcare facilities as we have seen in other countries. So our appeal is that let's all work together, and this is a national epidemic, and everybody is important, and we expect your cooperation. Thank you very much.
Thank you very much. Thank you, Professor Koleka Mlisana. Thanks for clarifying the fake news. The tests that we do are sterile tests, and people must not listen to the fake news. But for your interest, we have reported that matter to the police, and we hope that they can find those who spread the fake news. We cannot actually continue with the campaign and get undermined by people who deliberately spread fake news. May I ask that Professor Brian Williams come in? Thereafter, we're going to pick up the questions that you have sent. We've got some already. Thank you very much, Professor Brian Williams.
Thank you very much indeed for arranging this and organizing it. Professor Karim reminded us that our epidemic pattern is unique. The question is, why did we manage to stop the initial exponential rise so effectively when almost no other country anywhere in the world has achieved as much? Now, Slim made all of these points very clearly, but let me just focus on the ones that I think are important. I think there were two key reasons for this. The first is that we combined social and biomedical interventions at the same time. We did border control, social distancing, hand washing, and so on, but at the same time, we also mobilized a fantastic cadre of community health workers to test people, provide support, and do contact tracing. But the real key to all of this was to do them both very early. No other country started as early in the epidemic as we did. We managed to put out the small fires, to use Slim's analogy, before they had become a conflagration. What I really want to say is that all of this depended on this very strong leadership and clear vision of the minister, the insight of people like Professor Karim, and the commitment and dedication of the community health workers who are on the front line. I would like to think that what we have achieved will become the gold standard model for how we respond to future epidemics, which will surely come. So just congratulations all around, but especially to Professor Karim on a brilliant presentation, and I can't add any more for the moment.
Thank you very much. Thank you very much, Professor Brian Williams, for your comments. We're going to ask that some questions be tabled so we can respond to some of these. And I'm going to ask that the panelists can pick up if they wish to. We'll also just assign some of the questions. So could we have the questions, please, at this point?
Thank you, Minister. The first question is from Leandri Hetting. Her question is, please explain the immediate drop in case numbers on the day of lockdown. We know the incubation is no longer than a day, and there will have been a further lag in obtaining test results. It's Dr. Hetting.
I'll address that issue. So let me explain the 2-week delay. So when we talk about a case today, that person became infected 2 weeks ago. So we want to know what happened 2 weeks ago that either created the conditions for this infection or created the conditions for an infection not to occur. So when we talk about the fortnight after the lockdown, what we are seeing in effect are the benefits of the actions taken in the 2 weeks prior to the lockdown. So that is from the date of the state of disaster. So that's the date on which we closed the schools, we reduced the gatherings, it's the date on which we closed the borders to flights and so on. So all those actions are responsible for driving this downward slope that we saw. The 2 weeks before the lockdown reflects the time period because everything has to be shifted 2 weeks earlier. So the 2 weeks before the lockdown is actually reflecting infections 2 weeks before the state of disaster. What does all that mean? It gets a bit complicated because you've got to keep thinking about the shift of a fortnight. In summary, what we have been seeing is the net effect of the combination of interventions. All of the things we did in the state of disaster and now the state of lockdown, the lockdown effects are now slowly going to kick into gear. And that's what we are seeing as we see this decline in the number of new cases.
Thank you.
I think I'm convinced that India is a very good example. They have extremely good data, and they did a lockdown, but the lockdown appears to have had no significant impact on the epidemic trend. And I think for us the key was starting very early, before it had spread, so the effects could be seen much more rapidly. That is the only explanation I have for the rather abrupt change in the rate of increase.
Thank you very much, Professor Williams and Professor Abdul Karim. Could you take the next question?
Thank you, Minister. The next question, there are a number of questions that have been asked by participants regarding the use of masks by the public.
We have now got the totality of the data through systematic reviews that have been undertaken on the value of masks. And they range from medical masks, such as N95 respirator masks, surgical masks, to non-medical masks that involve masks made from cloth, from plastic, from paper, and there's a whole range of materials. I'll simply refer to them as cloth masks or non-medical masks. So what do we know? The evidence comes probably most compellingly from a paper just published in the journal Nature Medicine. In this study, patients who were exhaling the virus, who were exhaling coronavirus, exhaling influenza virus, and exhaling rhinovirus. Those three viruses were being exhaled by these different patients. They put masks on half the patients, and they left the other half without masks. They then measured the virus that was present in exhaled breath that was in those who were using a mask and those who were not using a mask. What they showed was quite interesting. What they showed is that when you take coronavirus, in those who were not using a mask, between 30 and 40% of those patients, you could detect coronavirus in the exhaled air. And it's really in the little droplets that as you speak, as you cough, as you sneeze, the virus is present in those little droplets. In those who were using a mask, they found none of the patients had coronavirus in their exhaled breath. So that gives us a very clear indication that if you can cover the mouth so that the droplets can't get out, there is no virus in the exhaled air in those who are using a mask. Now, it's a small study, but it certainly gives us an indication that masks are effective in preventing coronavirus coming out of people's exhaled breath. The same effect was also seen in influenza virus, but to a lesser extent. Masks had no effect on rhinoviruses. Rhinoviruses are present whether or not you wear a mask. Rhinoviruses cause a very mild little cold. So if we look at those three viruses, on the basis of that, we are pretty confident that masks prevent the virus from entering into all the environment if you're wearing a mask. A mask does not protect the wearer. If a person is wearing a mask, it does not protect you. We know that now from several studies that the evidence for the protection is not there. There's some suggestions it may protect, there's some suggestions it may not protect, but the evidence right now is lacking for whether it protects the wearer from the coronavirus. But the net effect, if every one of us wore a mask, a cloth mask, then all of those individuals who are coughing up the virus will then be able to contain it, and it protects all the rest of us in the process. So the question that's quite important to accept, that not only do these masks provide us as a general protection in the community, and so everyone should wear a mask, we should make it very clear that the general public should never wear a medical mask. They should not wear a surgical mask or an N95 respirator mask. Those are needed for healthcare workers who are working in very close contact with patients who have the COVID infection. So we need to respect that and keep those because they're in short supply for our healthcare workers. The second is that because the masks don't necessarily protect the user, we have to make sure that people continue to wash their hands, sanitize their hands, and that they continue social distancing. The most important thing, wash your hands, sanitize your hands. Next, social distancing. A mask is only number 3 on the list. And finally, if you're going to wear a mask, be very careful how you handle it, how you put it on, and how you take it off. If you're going to use a mask, remember that when you take the mask off, never touch the inside of the mask, because that's where all the viruses are. So you will undo all the benefits of having used a mask is when you take the mask off, you go and touch the inside of the mask. Instead, take the mask out very carefully, fold the inside, so you're only touching the outside, and then you take it and you wash it, put it in warm water and soap, you wash it, and dry it properly before you use it again. So we advise most people, make sure you have 2 masks. One that's being washed and dried, and the other one that you are using. I'll stop there.
Thank you, Prof. Can we take another question?
Thank you, Minister. The next question is modeling also being done to estimate the medium and long-term health, socio-economic, and knock-on morality consequences of our interventions? Are the side effects of our interventions being considered and monitored as part of the holistic public health response? Poverty is closely related to premature mortality. A bankrupt fiscus will be less able to supply an ongoing health care.
Thank you very much. Let me just respond briefly to that question. Yes, indeed, a lot of modeling is taking place to advise the President and the Cabinet on the impact of the coronavirus and the interventions that we're putting in place. We only just brought in the health interventions, but trade and industry and finance or treasury have been working on a number of scenario plannings as well as projections of what the impact will be onto our economy, onto the fiscus, onto specific aspects of the economy in terms of various sectors of the economy, and therefore all of that is being taken into account. This also includes the social impact of the entire, both the COVID-19 as an outbreak, as well as the issue of the interventions such as the lockdown. So all of these issues are being taken into account, and at the end of it, we are looking at the fact that we have a community that's got a huge amount of poverty, inequality, unemployment, and the economy has gone through downgrading with the various rating agencies, downgrading the economy of our country, as well as other challenges that relate to the supply of energy and other issues that relate to the interconnections between the various sectors of the economy that now, when we talk about what do we do with the lockdown, we have to consider the impact on those and how they are all interrelated. So we are not today talking about that, but we are simply saying that so far as the health aspect is concerned, these are the considerations. The reason why I said at the beginning that there is no decision that we're announcing here, it was because the decision have to be taken by the Cabinet and the National Coronavirus Command Council after taking in the totality of all the issues that have been brought onto the table. For example, some of the effect of the lockdown regulations has been the impact that it has had on the hospital admissions due to trauma and assaults and those kinds of situations. Now, but at the same time, we're monitoring the gender-based violence issues. We're monitoring the issues of mental health, incidences on communities under the circumstances that we're on. So all of these are being taken into account, but we're not coming here to report about them. Just to say, behind the actions and the decisions that the Cabinet and the President would have announced, there's quite a lot of input in terms of the experts that are giving us guidance on what the likely challenges are and the likely scenarios are likely to be. Thank you. Is there another question?
Thank you, Minister. The other question relating to masks says, can we reuse N95 masks given that there is a shortage in the private sector?
N95 masks are a very special kind of mask. They have multiple layers in them that filter out even very small organisms like viruses. So they are the gold standard of masks that we use in medical care settings where we are working very closely with patients, where we are working with them, handling them, and so on. So we need, for medical care practitioners, we need to use these N95 masks. At issue is with any mask, N95s only work for a certain period. And when they clog up and when the pores and the gaps in the material clog up, they don't work well anymore. As a rule, an N95 mask should last about a week. Now, sometimes it's shorter, sometimes it's longer, but basically you can work with that. Now, in some of the high-risk settings, where you're worried about organisms that may be on the masks, there you have to throw them away when you exit the facility. So, for example, if you're working in a high-containment facility, as we do in our laboratories, we throw the mask away as soon as before we can step out, because we don't want to take the bugs that are in the mask out into outside the lab. So in those instances, we control their use. But in clinical settings, where we are dealing with TB patients and so on, we can use an N95 mask for roughly a week. I would not advise the general public to use an N95 mask. It is difficult to wear. It is difficult to breathe in an N95 mask. Medical personnel spend a lot of time learning how to put it on, how to remove it. We call it the doffing and the removal. It's all done in a very specific way. I would not advise the public to even attempt to use an N95 mask.
Thank you, Prof. There's a question regarding contact tracing, and I will direct that question, Minister, to the NC for KwaZulu-Natal, who can just assist the public on what method they use to trace contacts.
Good evening, Minister. Evening to Prof and all the other professors that we've had this lovely engagement with. The question that has been asked is how or what methods are we utilizing to trace the contacts. Now, what we do once we have discovered and we've been informed that a particular patient have tested positive, we are then able to get the details of that particular patient from the doctor who had seen the patient or the health specialist that attended to the patient, and after that we engage with the patient and get the details of all the contacts that the patient has been in touch with. Now, in terms of the information that we need in relation to the contacts, it's your phone number, your physical address, and then we call each and every contact that we have been given. We have found, Minister, that in other cases, some patients would have more than 20 contacts or more than 30 contacts, depending on where they have been. And those people are individually called and are followed up. And what we also do is, once we have received the physical address of where the particular contacts live, we also go to their homes. And the intention of that is also just to assess, to make an assessment of the level of exposure of those people that are living with that particular contact, so that we are able to understand how far the spread of the virus has gone. And once we have been able to visit those particular contacts, and we are able to then assess and understand whether it's necessary to test them or not, and we do that through the screening. Thank you very much, Minister.
Thank you. Whilst we're going through that approach is the standard approach, let me just indicate that we're building up ICT capabilities, wherein we will be able to use messaging through WhatsApp to be able to reach out to people that you might be needing to reach. Particularly as the numbers increase, we will need that as a supportive way of assisting. At the moment, we do direct calls through call centers, as well as sending people on the ground, but we're going to be augmenting that with additional capability where an ICT platform is used, which will say, your name, good morning, Zweli Mkhize, we would like to talk to you about the contact, and so on, and then it will ask you questions, and then you will be able to respond and interact. When it comes live, we will talk about it. This is just to say we're going to be widening the capacity of government to be able to reach out to all those contacts so that we don't have a problem of numbers. But also because we've got community health workers on the ground, we will be actually increasing those numbers. We'll also be looking at NGOs who are also coming with additional numbers to assist us in the process. At the moment, we have been able to cope with the numbers of contacts that we have to deal with. Thank you very much. Next question.
Thank you. Can I just allow Professor William to respond?
I just wanted to add on a comment to that. If you think about it, one of the most important aspects of contact tracing is that it's a very efficient way of finding super spreaders. If you find contacts, you're more likely to find people who themselves have a lot of contacts. So just following the chain of contacts leads you very quickly to the people who have the most number of contacts. So it's actually much more efficient than you might think it would be.
Actually, we have seen that, Prof, you're quite right. One case in point was in Bloemfontein, where we had 5 positive cases in a church of about 300 or so people. For 5 days, everyone was together, so we were able to pretty much make up the entire list of who the contacts were, and therefore we could actually contact as many of them as it was possible. So the point that you are making is that it's not always impossible to do so. The other one are instances where someone was in a cruise liner, and then they say I was in this particular cruise liner, and then we actually get the manifest, the cruise manifest, where we get the list of people and the seating arrangements and everything. Then we know who are the people that need to be contacted. And they're not difficult because they bought tickets, that we have contact details left in place, and so on. So yes, it might be a number of people, but it doesn't mean that it is difficult to find who they are. So at the moment, I think we are trying our best on this one, but thank you, your point is quite correct. Thank you. Can we have the next question?
Thank you, Minister. A question to Prof. Should we test every single patient who presents with fever, sore throat, or cough? This net is cast very widely when faced with the normal colds and flu that are around. If we send a simple case, or uncomplicated or mild cases to test, surely they will sit in the waiting room next to a COVID patient, test negative at presentation, but pick up the COVID and go home with it.
Yes, thank you. So ideally, we would like to test everyone because we know that you can spread this virus even when you don't have symptoms. But that's simply not practical because that's 55 million people. So we have to choose who we test. We've set a set of criteria. So until a week ago, we created a set of criteria that deliberately prevented us from testing a lot of people, in that you had to have acute respiratory disease, but you must have also traveled overseas or had contact with a traveler from overseas or be a healthcare worker who had contact. So we restricted our testing. And so when you look at the testing we did up to about 10, 12 days ago, up to about 2 weeks ago, you'll see we did very little testing because the criteria were very rigid and very tight. And they were for good reason. They were criteria that were set to identify those who are most likely to be positive, but they were also criteria because we were concerned that we may not be able to do all those tests. The situation today is very different. You now already heard we can do up to 50,000 tests a day, whereas we're only doing something in the region of around 5,000 to 6,000 tests per day. So we know we have a huge capacity to absorb and to do these tests. That doesn't mean to say we should use all that capacity because the tests are not cheap. So we need to be judicious. And we've chosen to be judicious by ensuring that we are testing people who have an acute respiratory tract infection. So you can't be tested unless you have an acute respiratory tract infection. And we require that you have at least one of 4 symptoms that are common in patients who have COVID: fever, sore throat, cough, and shortness of breath. And in all of these, we know that from what we've seen from a study of about 45,000 patients in China, that these are the commonest symptoms that we have. The problem is that these symptoms are also common in other patients. But the particular acute onset that we are talking about, we are most likely to mix it up with patients who have pneumonia and patients who have influenza. So we've chosen to say we will test, and we've given high preference to patients who come in with a diagnosis of pneumonia. We've also given preference to those who have one of these symptoms together with an acute respiratory infection, so that we'll be testing all the flu patients and so on. I think when it gets to a point that we find we cannot cope, that's the point at which we'll have to tighten our criteria and look for a set of criteria that give us a higher predictive value of infection. We do not want to jump that gun, because we've already had quite a very rigid kind of definition of who we test. We've gone now the opposite direction of a very liberal definition to allow as many patients to test. When we get to a point that that liberal definition is counterproductive, then we need to think about how we ease that and make that more restrictive.
Thank you.
Can we take the next question? And please, if the other panelists, Professor Mlisana, Professor Gray, and Professor Williams, if they wish to raise an issue, they'll be able to indicate on the screen. Thank you.
Thank you, Minister. I've got a question from Adrian Basson. The question is directed to you, Prof. Karim. It says, can you please comment on whether you think any of the following factors could contribute to our unique trajectory: warm weather, the BCG vaccine, and our younger population?
There are probably many things that contribute, and we might not understand all of them. I can say that based on the evidence we have seen so far, this notion that our summers will protect us and that this virus won't survive our heat and humidity has simply proven not to be an accurate situation. The virus survives quite well at 37 degrees Celsius, which is our body. It grows, in fact, in our lungs at that temperature. So we know it survives well in quite a wide range of temperatures. So certainly our weather does not afford us any protection. The second is about BCG. And there are many views about BCG. I've been struck at how many experts there are on BCG now. When we look at BCG, BCG is a vaccine that's given to protect people from severe forms of tuberculosis. So BCG is not really effective to any significant extent in preventing tuberculosis. Right? If it did, we wouldn't have tuberculosis problem in this country. It doesn't prevent tuberculosis effectively, but it prevents severe forms of tuberculosis. So a group of scientists from the Department of Osteopathic Medicine from a university in New York wrote a paper, which hasn't been published yet, I've only seen the preprint, in which what they did was they compared countries that have universal BCG policies with countries that don't. And what they show is that countries that have universal BCG have less burden of the coronavirus infection. Now let me explain why that's fundamentally flawed. It turns out that when you look at Europe and the US, where TB is not a big problem, they do not have universal BCG policies. And they are the ones who've had the worst epidemics. Africa, where BCG policies apply almost universally, the virus and the epidemics haven't hit us yet. And because you are comparing the situation at two different time points, you are assigning this to BCG when in fact it might simply be a function of time. So this is what is called an ecological study. It's very flimsy evidence. But what it is, and what I view it as, it's an interesting hypothesis. And somebody should do some research on patients who have BCG and patients who don't. I asked our colleagues in China whether they saw any difference in patients who had BCG, and the answer anecdotally at this point is no. So we don't know whether any of these country-level analyses, which are highly flawed because they are so prone to confounding, that whether that would make any sense. So right now, is BCG helping us? Let's just say I would love that to be the case, but I'm really skeptical that it has any influence. I will wait for the data to make up my mind firmly one way or the other. And lastly, the issue that was being raised, I'm trying to remember the third issue. It was the weather, BCG.
Youth population.
Oh, and the youth. Ah, that is a very important question. So many people have asked me, why is it Germany has such a low death rate from coronavirus? What's special about Germany? Besides the fact that they have universal health coverage because they have national health insurance, what was really important, and this is in a paper published in the journal Nature. So I'm just quoting from that article, which you can read in that it gives you a lot of detail as to why Germany's epidemic had such a low mortality rate. It turns out that many young Germans in the winter of Germany, that's in January and February, they go to the ski slopes of the Italian Alps and the Austrian Alps. And that many of them picked up the virus when they were on the ski slopes. In other words, while they were on holiday in these ski resorts, because the virus was spreading rapidly in Italy and in Austria at the time, they got infected. Young people have a much larger proportion of young people have a mild condition. And the death rate in young people is very low. So because Germany, the large numbers of young people got infected and the death rates are very low in young people, it skews their death rates to the lower end, and that the older people did not get infected to the same extent. So that explains why age is important. And I think, so I've got to say this very carefully so people don't take it the wrong way. Africa has a very youthful population. We have a very small proportion of our population above the age of 70. So we would expect that the large numbers of infections that occur in our country will be in young people. And that there will only be a much smaller proportion in the older people because we have so fewer older people compared to, for example, Italy or the UK. So we should expect a very different picture in the overall epidemic. But this is based purely hypothetical. It's left to be seen what happens when this epidemic hits us. And it's going to be very important that we monitor it as the epidemic grows in our country so that we monitor what our death rates are in young people versus old people. And we know, for example, when children get this virus, they have a very mild disease. In fact, most of them will not even know they got the virus and got it and developed immunity to it. So the very young are part and parcel of the population that we know will pretty much have a very mild condition, not needing medical care. It's only as you get older and when you have other diseases that we're going to expect you to have a need for a lot of medical care.
Thank you. I think we should try and round up. Maybe there are two more questions unless the other panelists would like to make a comment.
Yes, thank you, Minister. I'll allow Prof. Mufana just to make a comment?
Thank you. On the question of testing, just one extra point, that someone was concerned that people with mild disease might, because they come for testing, they might expose themselves to, to COVID infection. Let's just keep in mind that when you come in for testing, we are ensuring that at the testing sites, there are strict infection prevention and control measures. So anybody who comes in, they will be donned appropriately, washing of hands, and even the person who's collecting the samples, they will actually be donned appropriately. So people must not worry and think that, just because I have mild symptoms, it's not necessary for me to come up for testing. But we need to test even those mild symptoms. As Slim has mentioned, we have relaxed now the testing guidelines so we can pick up as many infections as we possibly can. Thank you.
Professor Williams?
Thank you.
No. Professor Williams has his hand up, please.
If I could just add a note to Slim's comment on age, I think we don't pay enough attention to age. In the United Kingdom, where they have very good data, if you're under the age of 30 and you get infected with COVID, your chance of dying is 1 in 500. At my age, it's 1 in 10. So I'm 50 times more likely to die if I get infected than somebody who's 30 years old. In fact, recently in Geneva, they released data to show that in Geneva, where the age distribution is not the same as South Africa, 97% of all deaths were in people aged over 60. So the deaths really do kick in at older ages. The younger people, not to say they shouldn't take care, they should be responsible, but the chance of dying, even if they get infected, it's actually very low. And we need to factor this into all of our calculations and control and the way we think about it.
That's fine. I think let's proceed. Let's take
question.
the last two questions. The last one? Yes, last one question.
Minister, we have a number of questions, and we will request the panelists just to assist us to respond to those questions. We will ensure that they are posted on the department's social media page together with the minister's social media page. Some of the questions that were asked together with the responses from the panelists. Maybe just to close off, Minister, there is a question that has been asked to say, is the minister a medical doctor? And I think we will use the opportunity, Minister,
I want to comment.
just
To comment.
respond to that question, to say, indeed, Minister is a medical doctor. He did obtain his MBCHB degree at the University of Natal then, which is now KwaZulu-Natal, in 1982, Minister. And I think this is just an opportunity for him, the honor by His Excellency the President to appoint him as the Minister of Health has given him an opportunity to go back to his first love, which is medicine and assisting in providing health care, quality health care to our citizens.
I'm just going to add to that. So I can provide confirmatory proof that Dr. Zweli Mkhize is a genuine doctor, because he was in medical school the same time that I was. And he and his wife, Dr. May Mashego Mkhize, were in the class ahead of me. And he was the president of the SRC, when I was in the SRC as a young medical student. So I can vouch that he did qualify in medicine, and I can vouch that he did qualify in student politics.
Thank you, Prof. On that light note, we'd like to hand over to the Minister just to wrap up the platform.
Thank you very much. Colleagues, thank you very much, Prof. and MEC and all the panelists, Professor Glenda Gray, Professor Kolega Mlisana, Professor Brian Williams, and all the guests and all our experts out there. We want to say thank you very much. I just want to get back to where we started, that this was basically to give a glimpse of the stuff, the science that goes behind the decision-making within government, guiding President Cyril Ramaphosa and his cabinet. And it is actually for us a real pleasure to be part of this discussion, because the nature of the campaign we're dealing with relies very much on community participation. It also relies too much on the factual information being shared so that we can continuously exchange. And we also need to focus on trying to use science and avoid fake news to guide our actions. I think the points that have been raised, in particular, the question of the protection of health workers remains paramount, and I want to reiterate that commitment at that level. I think the point that has been raised about looking at the exponential growth on South Africa, escaping that as it has happened, I think we have got a very promising approach, but nevertheless we must know that this pandemic is behaving the same everywhere. What changes is the behavior of that particular nation or that particular community to be able to effect a different kind of impact. And part of it is already what we are seeing, that there are indications that with a particular kind of conduct, we might be able to influence the conduct of the outbreak. We are about flattening the curve. We're buying the time. Therefore, we are trying to push out the peak of the curve to as far as possible away, so that we are able to reduce the numbers of people who get infected, so that we don't overwhelm our health services. But that at the end of the day, there are many factors to consider. It's not just health issues, but there are socio-economic issues and so on, which are also being looked at. The plans that have been indicated in another session will be able to indicate how far we have gone in dealing with those particular issues. I think the point which was made by Professor Gray, Glenda Gray, that this is a long march, and it's a march that demands national unity. It's a march that requires us to focus and know that each and every person's action will count. I think Professor Mlisana raised it that way. Each and every person's actions count. You are protecting us as a nation through your actions. You are protecting yourself as well as an individual. But we must know that we can only defeat COVID-19 collectively as a nation. And therefore, whatever plans there are, whatever decisions, we need to work together. We know it is difficult. We know that in some instances, difficulties in accessing daily requirements might be a challenge. We know that in some instances, our inability to get to work, has really compromised our ability to provide the adequate food for our families. But we want to say that there has been an impact on the conduct of the infection from the way that you have, as South Africans, conducted yourself. All we're asking, can we work together on this path? Can we make sure that we take one step at a time, and using the science, using the information, and using all the decisions that have been taken, try and see to what extent we might be able to buck the trend and move in our own trajectory that will ensure that fewer South Africans get infected, that fewer South Africans succumb to the infection, that our health services do not get overwhelmed, but at the end of the day, that we support each other, we support our health workers, we support all those who are actually giving us the support, that at the end of the day, we'll be able to turn around and say, we've done our best, and that we've been able to save our nation from a decimating infection that has ravaged the whole world. With that, I want to say once again, thank you very much to President Cyril Ramaphosa and the National Coronavirus Command Council, who have allowed us to go through and share some of the discussions that are going on behind the scenes, just to take our community, our society into confidence. And therefore, we want to thank the media for the continued interest and reporting on this matter. To all of you who have been part of this, we wish you a good night and thank you very much. May we bring this meeting to a close. Thank you.